Welcome to our channel Ortho Clinic. I am Dr. Ali Taib. I'm going to talk about shoulder instability, the glenohumeral joint instability. In our lecture about anterior shoulder dislocation, we mentioned shoulder instability as a late complication of anterior shoulder dislocation. Start with the anatomy of the glenohumeral joint. This joint is articulation between the glenoid fossa of the scapula and the head of the humerus. It is a synovial joint with the widest range of joint in the range of motion in the body. This is why it is prone to different injuries, especially dislocation of the shoulder, which might result in recurrent dislocation or instability of the glenohumeral joint, usually anteriorly. Please refer to our lecture on anterior shoulder dislocation for further details about anatomy of the shoulder. Stability of this joint depends on the capsule of the joint, outside to the capsule or thickening of the joint capsule, which are the glenohumeral ligaments. The labrum is a rim of cartilage around the edge of the glenoid fossa. This adds to depth of the glenoid fossa. Other stability factors are the muscles, especially the rotator cuff muscles around the shoulder. Also, the deltoid muscle is main muscle which gives this joint some stability. The pectoralis major in the front and the latissimus dorsi at the back add additional stability. Also, the long head of the biceps muscle which goes over the joint gives stability. The problem of instability presents with poor strength in the joint, poor strength in the limb, poor range of motion or pain. Pathoanatomy of shoulder instability. The joint, when it dislocates first time, this might tear the capsule and avulse the labrum. This is called Bankart lesion. Other intra-substance capsular tears might occur. Subscapularis muscle might be affected. Also, the bone of the humeral head might be indented. This is called Hill-Sachs lesion. Diagnosis of instability of the shoulder depends on history, examination of the joint, X-ray, MRI, CTA, and arthroscopy. History, illicit number of episodes of dislocation, the degree needed to cause the dislocation, and the position in which provokes the symptoms. Mechanical symptoms occur due to bony lesions, catching or locking of the joint. Examination of the joint compared to the other side. Examine the passive and active movements of the joint. Also, we examine for apprehension test and relocation test which denote Bankart lesion or anterior instability of the joint. In revision surgery, the shoulder is usually unstable in external rotation. It goes to the maximum of external rotation. This might mean subscapularis damage. Other tests like anterior and posterior draw test. This shows multidirectional instability of the joint. Sulcus sign denotes inferior stability of the joint, and slab lesion is detected by compression test. In case of shoulder instability, we examine the nerves in the upper limb, especially the axillary nerve, sensory and motor functions of the axillary nerve, and other nerves like the median, radial, and ulnar nerves also examined. X-rays are useful to detect the Hill-Sachs lesion, case of instability, and other fractures of the glenoid also can be seen on X-rays. MRI will show soft tissue injuries like Bankart lesion or slab lesion or damage to the capsule. CT scan might also be helpful, CTA especially. Treatment of shoulder instability. Two ways of treatment: arthroscopic repair or open reconstruction of the joint. The goal of instability treatment is to prevent recurrence of dislocation of instability, maintain normal joint motion and function, minimize postoperative morbidity, prevent complications, and return patient to original function as soon as possible, and give reproducible results. Arthroscopy is used for diagnosis and treatment. Diagnosis of Bankart lesion or superior extension, osteochondral and chondro-osseous lesions, pericapsular tissue damage, and anterior and inferior glenoid damage or Hill-Sachs lesion. Prerequisite to arthroscopic repair, usually in case of rheumatic lesions and unidirectional instability, Bankart lesion with healthy labrum and capsule tissue. Proper reconstruction. These operations are time-tested and reliable. Preferred for approach which gives anatomical repair and good function. Open reconstruction repairs, Bankart lesion operation, Bristow procedure, nearest inferior capsular shift operations. Bankart and inferior capsule shift operations are anatomical and they give better results. Thank you.